want to say thanks to Matt. After this presentation, which technically I'd like to say pretty much have my master's degree. So this is my capstone. I had to come up with a problem that I saw in the organization, and I had to troubleshoot it, have findings, and come up with a proposed solution, so to speak. So I chose interoperability with system support. The reason why I chose this is specific to us being a joint venture and just having to work with different system supports, different systems, different hospital EMRs. And the fast-paced world we live in, we need the information about patients now to make good clinical decisions. So here's the agenda. I'm going to touch on the interoperability of the definition rather of interoperability, the background, relevance of the research I conducted, the purpose, method, the findings from it, my recommendations, and then we'll finish with a conclusion. All right, interoperability is the ability of two or more systems to exchange health information and use information once it's received. I was really thinking, we just had a meeting the other day, and we were talking about a code blue that we had ran on a patient and not having the right micrograms per pump with whatever, with Spectrum's equipment and ours, and contacting the provider to upload these algorithms into our pumps. So we had that, right? I mean, that's just a plain, simple example of equipment talking to each other, having the right algorithms loaded in them. Care Everywhere, to me, is a great example of health exchange information that we use on a daily basis. We have the increased need for efficient interoperability with hospitals due to various reasons. I touched on some of those. Our joint venture, the fact that, you know, unlike a lot of healthcare organizations, well, I guess a lot of healthcare organizations do this, we take patients from a very wide range that come in all over, so we're getting medical records from everywhere. And then system support really in this research was anything technical, help desk, or information systems related. All right, the background. As of 2017, there was 186 IT developers that supply the 4,500 non-federal acute care hospitals. These are hospitals that partake in the medical health record EMR and EHR incentive program. When I sat down with Matt, as I have throughout the duration of this project, LTACs are not eligible to partake in this particular Medicare incentive program. But I found this stat interesting. Of those 4,520 hospitals, 96% have some type of established IT support. They have a help desk number, they have a ticket system. So pretty much every hospital to date across our country now, it's standardized. If you're going to operate a hospital, you need technical support. There's 6,000 total hospitals in the United States, 6,000 plus, and there's numerous HIHs such as ourselves. And we are one of these hospitals established in 2017. The relevance, I was able to pull some good research on the relevance of IT and technical support in the healthcare system. Manufacturers are flooding the market with different types of devices that use various protocols and programming languages. In order for professionals and doctors, nurses to exchange data in real time and be of actionable use, these medical devices need to speak the same language. So, our blood gas example is the bane of my existence. Those systems are literally just not speaking the same language. It's as simple as that. We're inputting the data in one Epic system, another Epic system can't translate this and give us those results. I mean, and the reality of that is that there's interoperability there. So the amount of information and network support that has to transfer among organizations is mountainous. It's every day. Information is at Wien Rounds yesterday, the ID doc literally did dictation on his phone and said, it's in the medical record. I mean, he's like, I pay $100 for this software, I love it, right? So information now is now. We need that in the patient's chart and we need other people to see it. And then placing a specific workflow process for interoperability mishaps and defining key variables to troubleshooting. All right. A study from Johns Hopkins showed that medical errors is the third leading cause of death in the United States. That's kind of scary, right? We don't get the blood gas results and the patient dies. That's the third most common cause of death in the United States of America. So the need to work and troubleshoot through these systematic issues is, the relevance is very high. Due to the increase of EHRs and EMRs, you know, there's going to be more struggles, kind of growing pains as well along the way. So with this, I really wanted to find the best practice to overcome these issues with hands-on and in-person experiments. So the overall purpose of this is to increase the quality of care delivered to the patient, freeing time that the immediate caregivers and healthcare leadership absorb on the phone, dealing with technical issues, working through tickets, is unparalleled and imperative to escalating high-quality patient care. The purpose is to summarize and conclude the best mitigation techniques behind these complex network structures and advocate for a more robust network solutions communication program along with financial resources to make these gains happen. All right, so I've been in touch with a lot of people throughout the duration of this research project. Key stakeholders, I've analyzed technical support, equipment, expanded the knowledge of our venture network support system, reviewed clinical data, leadership feedback and support, dove into electronic health records on multiple occasions. I've done personal interviews with staff, with providers, and that last slide there is kind of some of the people who have been involved throughout the duration of this. All right, review of Epic and EMRs, like I stated. I did have a key leaders meeting. I reviewed the current interoperabilities, especially a lot with our lab things, a lot of the things that I've worked, Aaron's not in here anymore, but we've worked on a lot of interoperability issues. We're working on one right now, right? That same code where we had an interoperability with the pumps, we have an interoperability that we don't have the ability to order a super ABG in our system. The interoperabilities are countless. And then at the end, the published findings, recommendation, conclusion is kind of the layout of the land here. All right, so correct me if I'm wrong, Suzanne, but we have a tier 1, 2, 3 system, right?
Yes.
All right. So an interesting article I found, a firm that is solely tier-based cannot offer high-speed clinical system support, and this is an attack on you, sorry.
Oh, no, I agree.
Cannot offer high-speed clinical system support to physicians and other clinicians. Today, clinicians need and expect immediate one-stop issue resolution, including issues with EHR. They cannot afford the time to explain to a tier 1 analyst who doesn't know the system, to be handed off to someone else in the EHR. And then if the tier 2 agent still isn't highly proficient, they're handed off to yet another more qualified agent. MedSphere 2018. This is also the bane of my existence. I can't tell you guys how many times I'm teaching people on the phone from our technical support system, this is where you find this in Epic. It's just not appropriate. If we're calling people, there needs to be a different structure to where, and they need more customization of the ticket system in itself to say, I've been working on this issue for 6 months. I don't need to speak to another tier 1 analyst who obviously cannot resolve this issue. And that's what we find. And it's just it's a cyclical loop of telling them the same information over and over for an issue that we've worked on. Talking to the select medical director, she stated to Aaron and I, we used to have a previous list of technical lab order and support issues that, what's his name, the old DQM? I can't remember. TJ had a list with our medical director in the physician lounge, arterial blood gas, film array, bronchial or alveolar lavage. Everything that we were working through as far as interoperability, we used to have on paper. That doesn't exist anymore, and she said we need to bring that back. So we have these interoperabilities. Sometimes you just need it in your face to remind you people could die if you don't get these blood gas results, right? So that's definitely something that you may want to look at. I think, and I wish Aaron was in here, but I think they kind of rehashed that out and maybe got that list going. House supervisor interview. Technical support system is frustrating, extensive, requires multiple unnecessary follow-ups. We need more buy-in from both Select Medical Support Management and Spectrum Health. I had a call with Brandon, the manager of Select, as well as Mike and Aaron, some of the lead technical support people. They stated, hey, we'll get you some knowledge articles so that you can push out to your staff. This is the best way to work through a ticket system so that we can have a more efficacious workflow for that. But unfortunately, I know people are busy. I followed up with a couple times. I wasn't able to get those knowledge articles from those members. One thing that was stated is we're a national organization and we're not really going to hone in on one facility to make these changes. So it may have to be something that's done more on a local level. Contractual agreements with the host hospital, Spectrum Health Organization to complete numerous clinical and non-clinical workplace tasks. So a lot of things, they're all linked together. Even when it comes to a fire marshal visit and we have to put in a work order, that's an operability thing between systems to get those physical things done. Other things that relate to interoperability: contingent worker access, badge and security related functions, physical building structure deficiencies, joint commission fire marshal visits, inpatient procedure travels, lab procedures or results, equipment biomedical procedures, security related, emergency management policies, electronic medical records, networking applications, all require operabilities between numerous systems. From my findings, what I've summarized, an average interoperability, and this is mostly related to just specific EMR laboratory things, is an average of 3 to 6 months to fix. We're post a month and a half from knowing that we can't order super ABG in our system right now. How long is it going to take before we fix that interoperability? We need this information, we need it now. The doctors need to know those critical values now. That's why they want to order that super ABG. So we'll see. My guess, 3 to 6 months, maybe longer. My recommendations: senior level management with both Select and Spectrum to push to increase resources to streamline the technical support system to speak or talk to each other. What I mean by this is the Select Medical Network support team said they do have different ancillary services that do have minimal access to their tickets, right? Because if I put in a ticket, I don't know all the intermeshings of these network issues and mishaps. But if you have a Select and a Spectrum IT person that can both see the same ticket and work on it together, I don't have to call 20 times and say, what's the status of that ticket? And tell them all over again what's going on, right? They should be able to work on it as network support systems professionals. Advocate that a hospital have a host technical support enhancement policy be trialed and reviewed. Look guys, internet and network support is not going anywhere. Why don't we have a structure to it, some rigidity, that if you're a hospital within a hospital, these are the way that the network, and it's tough, it's complex because each hospital system's different, but it may be something to look into. Modify or abolish the tier 1, 2, and 3 technical support system altogether. It just doesn't work. Research is out there. People have to just keep repeating themselves. And then another idea I had, specific managerial level positions, so everyone in this room would have special access to the next tier. The thought process is if you're a manager, you're going to use your frontline resources first and know some extent of what's going on, to where if you have that access, I would call straight to tier 3 on our tier blood gas. It's been 4 years, right? Why do I want to talk to a tier 1 analyst about this problem? Specialized technical support work group. So an email thread of 4 emails. Once I got a network support Epic specialist from Select and a network support specialist from Spectrum, they fixed the problem in 4 emails that Aaron and I were working on for 6 months. It was that simple. Bronchoalveolar alveolar lavage, we could not get it in our system. APP team couldn't order it. We're calling people, talking to tier 1 analysts, doing all this stuff. And then I say, hey, I emailed this guy, they did some stuff that we don't have access to, they used a fake patient, they ran like fake labs in Epic from on their support side of things, and he was like, does that work? Yeah, it works. Boom. The next day, I have the APP team order an alveolar lavage, it works, right? We need the right people that know how to do this linked together, and they need to talk. This is the work group. My recommendation would just be an email group. Some of these people may not have to be involved, some may be involved, but one email with these people could curbside a year project is the reality of it. All right. From a financial standpoint and from Medicare, Medicaid, 2018, this is recent. They're having a push at these conferences for new interoperability initiatives within the healthcare record. So, the government's looking at this stuff too. And maybe it's not long before they say, hey, need to look at this. I think, this is more of a personal opinion, but why did Sears and Toys R Us go under when Walmart and Amazon thrive? What do Walmart and Amazon do? What can you do? You can go online, you can use their whole massive network support system and order anything anywhere. These first two didn't make the push to have network support and have online sales. The reality of any consumer-based, even if it's patient care delivery, we have to have those resources from a network standpoint. More robust technical support system where patients could suffer suboptimal care. Our financial gains will decrease. You're going to have staff burnout, provider dissatisfaction, and more. And then more resources from senior management. Like I touched on, abolish the 1, 2, 3 tier support system. Those are the references that I utilized for my research and capstone. Does anybody have any questions, comments? The end.
Are you aware of any pushes? Like I know there was a push there for a while for like the Michigan Hospital Health Information Exchange, where it was like mandatory that everything would have the SSL7 interface, and like that you would have to basically build your components so it is transferable. Did you see anything in your research regarding that?
I didn't look at, because I know, wasn't there something that came out, obviously within so long that so much of organizations had to have like electronic health records too. Mm-hmm. So, I know that that's the beginning phase of it, and paper charts are highly phasing out. I haven't seen anything. I didn't dive specifically into like you're gonna have to do this because research. Mm-hmm. I wouldn't be surprised if it doesn't come down the pipeline and they say, hey, look, if you're not gonna take the step to make sure that you can have the communication processes in place to care for patients, like we're gonna make you. But I didn't pull up any specific research on that. All right, I'll turn the meeting back over to Matt. Then thanks, guys.